When I started my new role as a population health specialist, they joked like, okay, maybe it's not an emergency like what you're used to in a hospital, but it's an emergency to us.
Welcome to Nursing Beyond the Bedside. I'm Audrey, your host, and a nurse who pivoted my path several years ago. After 8 years as a critical care nurse, I was ready for change. I craved higher pay and more flexibility, but was struggling to find a clear path forward. Fast forward through positions in recruiting, customer success, and marketing, and many lessons learned along the way. Today, I run Pivot Path, a company dedicated to empowering nurses to redefine their careers. This podcast is designed to help you navigate the journey from clinical bedside nursing to a fulfilling career that aligns with your passions and goals. Here, you'll discover inspiring stories from nurses who've gone beyond the bedside, successfully transitioning to non-clinical roles or redefining their nursing career. Join us as we hear their stories and share actionable strategies to help you make your own leap. Whether you're a new listener curious about what lies beyond the bedside or a returning audience member in need of some fresh motivation, this podcast is your go-to resource for exploring new opportunities that can transform your career. Let's get started. Welcome to Nursing Beyond the Bedside. Today, I'm excited to introduce you to Natalie Donnelly, a nurse with an incredible journey from bedside to population health. Natalie grew up in the Upper Peninsula of Michigan in northeastern Pennsylvania, where healthcare was practically in her DNA. She proudly graduated from Michigan State University College of Nursing in 2015, working as a CNA throughout school, which laid the foundation for her nursing career. From there, Natalie became an RN and a charge nurse for a 45-bed unit in Madison, Wisconsin, but she eventually made a big move to Chicago, where she took on a new role of insurance case manager. Today, she's working as a population health and wellness manager for an employee benefits broker, making a significant impact on healthcare from a whole new angle. Natalie is joining us from Chicago today, where she lives with her husband Jordan and their adorable city pitty Bennett. Natalie, welcome to the show.
Thank you so much. I'm really looking forward to diving in and talking a little bit more about what I'm doing and hopefully open some eyes and doors for other nurses.
Absolutely. Yeah, it's always interesting to hear kind of the non-traditional paths that nurses' careers have taken away from the bedside. Let's start with the very beginning. Talk to me about your just kind of initial exposure to healthcare from a young age and how you decided to pursue nursing in the first place.
Yeah, so I have been exposed to healthcare since day one. My dad is a recently retired hospital CEO, so that led to us living in all different areas from outside of Detroit to Kansas and then the Upper Peninsula of Michigan and northeastern Pennsylvania. So I really got unique exposure to different access levels of healthcare while living in small cities to very rural areas. What led me into nursing was being around healthcare and then wanting to go the avenue of nursing. I had an experience with a grandma on hospice, which was probably my first real interaction with a registered nurse as a child, and just understanding and starting to see how compassionate registered nurses are, but also how personal that career is. And I've always really enjoyed being around people. So nursing just felt like a very great fit for me. I like science. I like to work with my hands. So nursing just was a great fit for my interests. And then that's how I ended up at Michigan State to study nursing.
Nice. Yeah, I love the mix of interest in science and working with people and the personal experience. I talk to a lot of nurses who a lot of us have some sort of personal experience with healthcare or healthcare in our family that kind of leads us down that path. But there is definitely a science aspect to us too. I nerded out in my science classes. And so, nursing was like the perfect place to kind of apply and blend all of those things. What kind of nurse did you start out at? Like, how did you go from deciding you wanted to be a nurse at all to landing in any specialty?
Yeah. So when I graduated from Michigan State, I moved to Madison, Wisconsin. Madison, Wisconsin is just such a great city. A lot of three really amazing hospitals in that city. So I felt really lucky to have landed there. And from there, as a new nurse, from my clinical rotations, I felt more comfortable working with the adult population. So I started there. I wanted to go the hospital route initially to get that acute patient experience. So really, I interviewed on a heart and vascular unit and then a same-day surgery for outpatient procedures. Being novice in my clinical experience, felt like the cardiac step-down unit on the heart and vascular unit was a great fit. Like you already mentioned, we were a large unit, 45 beds, so we really functioned as an IMCU. So we would take step-down patients, some higher level acuity needs, general med. So it became a much more awesome blend of caring for all ranges of adult patients. So landed a rotating day-night shift on that unit, had amazing preceptors, and which allowed me to feel comfortable enough in my knowledge and skills to become a charge nurse after about a year and a half of being a floor nurse.
Nice. Yeah. Taking on charge nurse a year and a half in is a lot of responsibility.
Charge nurse was a really unique experience, especially during night shift, working with that slimmed down staff, less doctors on the floor, less respiratory therapists on the floor. But I loved that. I always have really valued leadership roles. So charge nurse to me felt like something that I wanted to aspire to. And then being able to staff for the next shift and really talk to the house manager to say, how are we going to staff? Here's what I'm thinking that I need. Our unit was acuity-based staffing, which I really loved that model. And using the acuity-based staffing, we would work with the other nurses, get their assessment and what was needed for day shift. So it was really a collaboration with really the entire hospital. Here's how many nurses we have available. How can we best utilize them throughout the whole, not only the floor, but the hospital.
Yeah, definitely. That seems like a good way to do it rather than just saying it's a certain ratio, no matter what the acuity. Acuity is a very important factor in that decision.
Yes, I agree. And my floor gave so much autonomy to the nursing staff too, and really valued their opinion on what that acuity of that patient was. So that was a great staffing model that we utilized.
Yeah. And so how long were you in that position?
So I was a bedside nurse for just under 4 years. After 4 years, my husband finished his law school degree in Illinois and wanted to take the bar exam in Illinois. So came down to Chicago, and Chicago is a big city with a lot of opportunity. And, this podcast alone shows that there's so many interesting careers that nursing can go into that I wanted to explore what else was out there besides what I thought of as a traditional nursing role.
Yeah. And so once you moved, what was the first role that you took in the new city?
My first role in Chicago was as a registered nurse case manager for Blue Cross Blue Shield of Illinois, so a huge insurance company. That role still allowed me to use my clinical experience, which is something that it would be really hard for me to give up my clinical knowledge and being able to utilize my clinical experience. But that was just an amazing experience. Working with an insurance company really opened my horizons to the full healthcare ecosystem. As a college student, we learned about disease processes. Here's the patient's journey from outpatient to inpatient and then back home, but never that kind of layer behind the scenes. I like to call it that my time at the insurance company was really peeling back the curtains and learning how prior authorization works, utilization management works, and seeing what types of advocacy the insurance companies are doing, specifically in my role as a case manager, where I was reaching out to members, is what we call them instead of patients, reaching out to our plan members and helping them either educate them on disease processes if they have a new diagnosis, because we're getting all this claims information on members, so we can see when a new diagnosis comes through, helping them transition safely to appropriate levels of care. We would work with the hospital systems case managers and find unique solutions, maybe if there's a skilled nursing facility that is full. So what other options can we leverage, as well as utilizing community resources. One of my greatest successes in that role, really unfortunate situation, a man was hit by a car and became a quadriplegic. And so I was working with his spouse on trying to get him home because he got in this accident a few states away from his home. And it was really difficult due to certain requirements of getting transportation home. So we were able to find volunteer transportation that could handle this member's acuity, as well as finding free community resources that were able to provide a free Hoyer lift to this patient, which allowed him to stay in the home instead of needing long-term care. So that was one of my really amazing successes and some things that are going on behind the scenes at insurance companies.
Yeah, definitely. Man, that is such an intense and complex situation. Having to think about all of the pieces of care that, not only to get him home, but the care that he'll need in order to be at home, like you said. How did you find that job? Were you looking for a job with an insurance company, or were you searching for case management? How did that come to be?
So my initial searches were trying to just think outside of the box. So again, this was prior to the COVID-19 pandemic, where I feel like a lot of unique roles have come up since then, and it's a little bit more well known of other avenues. So I was looking at some health systems, seeing what types of roles are there for nurses that aren't necessarily clinic work, but aren't necessarily bedside work. And through that, just because of the size of Blue Cross Blue Shield of Illinois in Chicago, it's headquartered down in the Loop. It's very well known, heavily advertised. You see their advertisements everywhere. So then that made me want to explore. My husband's mom works in insurance, oversees their case management and utilization for an insurance company in Michigan. So at that point, I didn't really understand what her job was because I wasn't exposed to it. But then when I was interviewing for Blue Cross, bounced off some ideas to her, and she's like, oh yeah, you would be like someone reporting to me essentially. So I was able to get some feedback from her on a little bit more of what the day-to-day details of that would look like.
That's awesome, because I feel like a lot of people, when they're searching for nursing jobs, it's hard to know what a job entails. Not only what to search for, but what the day-to-day of any position is going to give you if you've never worked in that setting. So did you know that you wanted to leave like bedside nursing at that point? Or was it more of just an opportunistic, like, this job sounds interesting, you talked to her about the day-to-day and decided to pursue it? Or was that something that was already on your mind?
When I moved to Chicago, I was looking for a role that would have a more defined work-life balance. Coming from the bedside nurse, my schedule was only out every 6 weeks in advance. I did rotating day nights, and that did take kind of a physical toll on me. I just didn't feel like myself. I wasn't getting out and exercising as much, and it was hard socializing with friends for me when I was off on a Tuesday and everyone else was off on Saturday and Sunday. So coming to Chicago, being in that newer relationship with my husband, I was like, I want to try to be able to have that work-life balance that matches my home life. So when I was looking for new jobs, that was something that I would look to see if it was in the job description of what hours were required for that position. But then if not, that would be one of the questions that I asked during the initial interview or HR screening, just to make sure that that kind of aligned out of the gate. So then, I wasn't wasting my time exploring a position, but wasn't wasting the other companies or organizations' times either.
Yeah, definitely. I totally feel you on that nursing schedule. It can be really hard. I mean, night shifts absolutely killed me. But even beyond that, like going into a hospital for 12 hours at a time, I mean, 12 and a half, 13 by the time you're actually arriving and leaving, it doesn't leave much time for anything else on your work day. So to your point, like it can be hard to exercise. It can be hard to like eat right and like really take care of yourself. So that it is a swap getting out of that schedule. I remember when I switched to Monday through Friday, at first I was like, I don't know how I feel about this because I miss my 4 days a week off and now I just have two. But then when I realized how my entire week played out and like I had a lot more free time on the days that I actually worked, then it was like, oh, okay, this makes a lot more sense for me. I'm same as you, like I'm off when my husband is, I have the evenings, I can run an errand during the day if I need to. So I think that there will always be a little bit of a battle between the 3-day work week and the 5-day work week. But you can definitely find like the right thing for each phase of life.
Right. And I found, interestingly, the one thing about being a bedside nurse that I liked was each day felt very fresh. You have night shifts coming on that's picking up what you didn't get done. And then it's that constant back and forth of, all right, I'll pick up where you left off. But when you're working a job like what I'm in now, when you have that standard 9 to 5, Monday through Friday, it can you can be very tempted to say, I'm going to work a few extra hours or I'm going to come in a little bit earlier to get something done because no one's working, 24/7 on a project and it
Right.
falls on you.
Yes, exactly. I know I went through that same transition and you have to learn new boundaries for yourself of like, okay, generally roles are different, but generally if you're salaried, it's like if you're coming in early or staying late, you're not getting that extra, overtime or extra hourly pay that you would be at the bedside. So it is important to kind of watch that and set boundaries for yourself. And I ended up just, learning whatever I don't finish today will be waiting for me tomorrow. And at the end of the day, nothing is life or death. It can wait, unlike some situations in the hospital.
Yes. And that's something that I mean, I've been in corporate America now for quite a while, and they'll often say, this is an emergency or this is extremely urgent. And when I started my new role as a population health specialist, they joked like, okay, maybe it's not an emergency like what you're used to in a hospital, but it's an emergency to us. And so it is funny just to really level set because kind of corporate terminology can be thrown around a little bit. And it's like, okay, hold on. There are people that are in true, true life or limb emergencies.
That is a unique perspective that we bring into any job that we pivot into is we know what life and death and urgent is. And, while of course there's different versions of urgent, it's not truly life or death. So talk to me how you went from that initial like kind of case management role into population health.
Yeah, so I was at Blue Cross for 3 years doing case management, and my manager, Carol Townsend, she approached me during one of my quarterly check-ins, and we had a pretty candid conversation during that time where we both felt like I was plateauing in that role. So she encouraged me to see what internally there may be that would interest me. So I didn't look internally, but again, like I mentioned, I didn't want to give up using my clinical knowledge. So really, there weren't any roles that aligned with what I was looking for. And honestly, I wasn't sure what I was even looking for. So I went back and I talked to Carol. And she said, well, if nothing's aligning here, you can't be bored in your job. You work many years for many hours each week. You have to be excited each day. And so she encouraged me to explore externally. And so I came across my current job with the Horton Group, who's an insurance broker. Didn't know really anything about the broker space, but the job description was basically looking for a clinician that had insurance experience and then, of course, the clinical experience. And I was like, well, this sounds a lot like me. So I went ahead and interviewed, and through that, it really piqued a lot of my interest. I've always been very intrigued by data-driven decisions, statistics. And so I figured it would be a great opportunity for me to even dive down and explore that unique interest of mine and seeing what population health really was about. And for me, I always like to say it was like pulling the lens back. So instead of working with individual patients or individual members, I'm looking at a large group of our clients, employees, and spouses, and then trying to identify risks and patterns within the population and bringing a unique clinical perspective to that data. Oftentimes, a lot of decisions with insurance and coverage and things is coming at it from a financial lens. Well, what is that going to cost the company? What is that going to cost the insurance? But using a clinical lens was something that was a shift for our organization and a shift for our clients that worked with us. Better explained, behind this claim or behind this high cost is an individual, and what can we do to, from a holistic nursing standpoint, better support that member with their condition? And two, for the organization, how can we control that cost and control that condition from becoming more severe and more costly to the member and to the plan?
Yeah, absolutely. And so I want to dive more into like your day-to-day responsibilities and kind of exactly what you're doing with population health. But first, can you give us a kind of brief lay of the land of the insurance world and how it might make sense for listeners to think about insurance plans, insurance companies, and insurance broker?
Yeah. So it is a whole new world. A lot of this was all on the job learning for me, but it is important to know because, as you know, if you've ever used the US health system or had to use any insurance, you can see how it can impact you or your family member. So let's just start kind of at the very what I consider basic. So funding types for a plan. There are a few different funding types, but for the sake of keeping it really simple, we'll say there are two. The funding types would be fully insured or self-funded, which is also referred to as administrative services only. So a fully insured plan is a plan that all of the risk is on the insurance company. So your employer pays a flat fee each month to have the insurance company deal with the risk of the claims. Oftentimes with fully insured plans, the insurance company is deciding what is covered, whether a procedure requires prior authorizations, how many physical therapy or occupational outpatient visits will be allowed for each individual member. So that risk is determined by the insurance company. So that's fully insured. Oftentimes we'll see that with smaller groups, but there are large organizations that are fully insured too. It's kind of dependent on your employer group's risk tolerance. It can be if they have a lower risk tolerance, they'll say, just give me my bill. I know what it's going to be each month and we can budget for that. On the other side is self-funded or administrative services only. So for those types of plans, the employer itself is taking on the risk, so is taking on the claims. And then the insurance company, what are they doing? The insurance company is allowing those self-funded plans to utilize their network. So still, is this network an in-network doctor, an out-of-network doctor? You get to leverage the special rates that the insurance company contracted. But the employer group is the one that is making determinations on how many physical therapy visits can you have? Are GLP-1s going to be covered for people for diabetes and weight loss? So it's just a unique thing to think about, because being on the health insurance side as a registered nurse in the hospital, oftentimes would be, you'd hear complaints specifically about the insurance company. They're not covering this, or why can't I get another additional physical therapy treatment, or I didn't know I needed prior auth. But oftentimes you may be on a self-funded plan. So I think that can just be a good tip to know for you as an employee, because maybe you need to talk to your HR or benefits team on if you want something covered versus going and talking to the insurance company if you want something covered, because you can make adjustments to the plan during renewal and things. So it was just very eye-opening to learn those different funding types, which is something that I wasn't aware of before working for an insurance company.
Yeah, absolutely. That is super interesting and not something that I think I ever knew before you and I talked. um, knowing that some companies, in these self-funded plans do take on the risk is, interesting. I would have always thought something not being covered would be something to go to my insurance company about versus my employer. So it's a fun fact. Good to know. And so where does a insurance broker come into the overall picture?
Yeah, so the insurance broker, I like to consider the advocate for the employer group. We're typically the ones that are going to be negotiating rates with the insurance companies. So, which would look, how does that impact the individual? Trying to keep your monthly premium rates down. If there's a complex claims issue, the broker will get involved because we have those direct contacts with the insurance companies on, trying to get a claim passed through or trying to get something resolved faster. So for me, it lined up much better than when I was at an insurance company, because I loved being back in that advocate role, right? Nursing, you're always advocating for the patient. And so in the broker space, I was like, oh, this aligns perfectly with me, because now I'm advocating for, a group of patients, the employees and spouses that are plan members. So I would say that's really the key role, is being the experts on the health insurance and then really going to bat for you with the insurance companies to get the best rates possible, look at network options to see what is best for that plan, and then helping resolve complex claims issues that, it's healthcare is very confusing, and adding the layer of insurance onto it too is. So we're really in that consulting role of trying to help the different organizations that we work with take some of that responsibility off of their plate so they can focus on their day-to-day job, and then we focus on the insurance aspect.
Right. Yeah, that makes sense. And I do like the advocacy role that you get to bring into that job every day. And so you are working to analyze kind of these claims to determine a population risk. So instead of looking at a single individual, you're analyzing data, claims, reports. Like, how do you determine what that population's wellness looks like, and how do you go about making recommendations?
So there is a different levels of data and access that we are able to get. So oftentimes, my primary source is claims data, which would be medical claims and pharmacy claims. I'm mostly working with the self-funded groups. Again, because the employer groups are taking on that risk, they have more access to the data, where fully insured groups, since it's the insurance company taking on the risk, they don't give out as much data on the claims information. So from my day-to-day, I'm working primarily with self-funded groups, and there's a few ways. So we do use a data analytics platform that takes raw claims feed data and then does data analysis to compile the data into different condition groups. And from there, that's where that clinical lens comes out. Things are in clinical terms, not in layman terms. And then it's looking at, well, how can I identify which areas of the population is something that should be focused on and is impactable? There's a lot of data out there that, it's nice to know, but you may not be able to do anything with it. Like, a lot of times, really catastrophic claims are, of course, unfortunate, but from a population health perspective, kind of that one-off incidents that it's going to happen. So how can we control for conditions or pharmacy spend that we know is going to be repeated behavior? So some things that I look at, specifically leveraging our data analytics tool, would be what segment of the population is causing the higher claim spend. So a few ways to look at segments. First, I look at the employees, the spouses, or the children on the plan. From there, I also like to look at any social determinants of health that may be able to be pulled in. So is it something where it's a rural area where there may be access issues? Are there provider gaps? We think of mental health coverage of having a long wait time. So is there something that is access related, zip code related? And now we're even getting data that we can upload based off of annual salaries or hourly rates that employees are paid. Because oftentimes socioeconomics is going to be a driver behind some of the higher chronic conditions within a population. So once I identify where that spend is coming from, then I like to look at what conditions are actionable. So oftentimes we can think of chronic conditions. I see the cluster of high blood pressure, high cholesterol, diabetes, specifically really unique things going on in the diabetes spend world, with pharmacy spend often outpacing the medical spend by goodness. Usually I see it like 90% of diabetes spend is on pharmacies. So, and we can think of that as like really amazing advances too, with GLP-1s, the GIPs, all of those. But there are really unique programs out there that you still allow members to get that access to that medication. 'Cause that's something I still truly believe in, is you as whether you're self-funded or fully insured, if you have your medical doctor, your nurse practitioner, or PA prescribing you a medication, I'll say 99.9% of the organizations that I work with do not want to be making that decision whether or not you can access it, but it comes at a cost. So there's interesting things around shifting spend to international drug sources, mail orders always been around, or even leveraging unique pharmacies that are out there like Mark Cuban's Cost Plus as being your primary benefits manager.
Yeah, that's interesting. Like I heard you say, you analyze all of this data. You can look at data all day long, but you're really looking for the things that you can impact and do something to improve. How then, just kind of describe to me the process of, here's this data, here's a problem that we think that we can, help improve. How do you provide recommendations or seek solutions?
So one key component of my job is vendor vetting. Oftentimes, when someone has a chronic condition or there's a pattern within the population, there's a vendor or a point solution that could be leveraged either via the carrier that may already have a partnership, or I like to go outside the carrier. What other unique innovations are being done? So a lot of my role is vetting vendors and seeing what type of peer review studies do they have to back up the product that they are trying to sell. And from a clinical standpoint, does that make sense for the population? So that's important too. Oftentimes I talk about when I'm meeting with a client, how comfortable are your employees and spouses with utilizing technology? Are they going to download an app? Do they even have a smartphone? Do they have reliable internet access? So a lot of those things you need to think about when you're trying to make a good recommendation. From there, once I find a potential point solution or vendor that may be a fit, I actually do a population health presentation in front of the employer group. Oftentimes I'm in the room and it's the CFO, sometimes the CEO, chief HR officer, and then their senior benefits specialist. So, the real big and primary decision makers within that organization. And you have to be able to get the buy-in from them to go on to the next step. So oftentimes, first it's breaking it down on here's the disease progression if it remains uncontrolled, and here could be the estimated cost if this remains uncontrolled, and just explaining what things are. Again, sometimes when complex medical terms are thrown around, people nod along, but they don't truly know what that means. So that's something that nurses are so valuable in, is we've been around so many chronic conditions and we can see how someone can have diabetes. And although diabetes isn't stage 1, stage 2, stage 3, we can talk about the different severities of an illness. And then from there, it's really making that case of what the ROI will be for that vendor you selected. And ROI is that return on investment. So oftentimes the CFO, the finance team wants to see that hard dollars. I love, if I can, to leverage any type of performance guarantee from the vendor to say, if we don't see claims go down for this condition, then we'll put our fees at risk. So that makes that more palatable to the employer group to implement something new.
Right. Yeah, as you were talking, I'm, kind of just checking off the valuable skills that nurses have that contribute to what you're doing. To your point, we're really good at taking some complex health information and distilling that down into something that is bite-size, makes sense, and is digestible by your person who doesn't have a healthcare background. Nurse communication skills are just really through the roof.
Talk to anyone too, right? So it's like you can kind of pick up on cues of who else is in the room, on if you need to spend more time on that subject, or if they get the understanding and you can move along to your next topic. You have really good intuition about how people are responding to what you're saying.
Absolutely. And to your point of people just can sometimes nod along, and a nurse is just the person to kind of pick up on that and sense, like, I know you're just nodding along, but you're not truly absorbing and understanding this information. Our interpersonal skills are great. And along with that, we are able to come in and pretty easily establish a certain level of trust with whoever it is that we're talking to. I think that we're very empathetic. We meet people where we are. We're good at explaining information. And so, in the role that you're in, I can imagine that being able to establish a relationship and build trust is ultimately going to serve you well in these conversations where you're trying to advise them on, how they can, save costs while also like improving their population health.
Yep, exactly. It's really having that confidence that what you're talking about when it comes to disease and different types of conditions. And so I like to say it's like a puzzle piece. So you've figured out where the issue lies in the population. So here's maybe 2 or 3 potential solutions, and then why each one of them may be a good fit. And so that's where that more so consulting role comes in. We want to give the employer groups all of the information so then they can make that informed decision on what direction that they want to go. Sometimes, maybe budget-wise they can't, but then it's a roadmap item to readdress with the next benefits renewal.
Right. Yeah, and we've just named a few here, but, have you come across other soft skills or, experiences that you developed as a nurse that serve you well in this type of position or this type of environment?
So I'm working with a number of clients. I can serve up to 600 clients. So these are organizations. So
Oh, wow.
tens of thousands of individual lives impacted. So with that, nurses are very good at being able to change their priority level on what needs to get done. That's something that you learn, especially in an acute care setting. You have plan A going into the day, and then med pass happens and you need to scrap your whole day. So being able to prioritize tasks is something that's been very useful within my role. We already talked about relationship building. That's been so valuable. And outside of that, just staying up to date too. Oftentimes I'll get asked, oh, so you're not a practicing nurse anymore. And I'm like, no, that is not true. I am still doing my CEUs every 2 years, and those licenses are up for renewal. I'm staying up to date and reading any new studies. So it is still that constant learning, because you need to be up to date on what is happening within the healthcare ecosystem and different trends that may be on the horizon, so you can best arm your clients with knowledge on things that they may expect. So I'll say the CEUs and that continuous learning that nursing has built in is something that I still leverage daily.
Yeah, absolutely. And, you are still impacting patients' lives. You're not hands-on with them at the bedside, but by the recommendations that you're making to these companies, like, you are still making an impact. And I'm sure that that gives you a sense of fulfillment. I think that a lot of nurses worry about losing their ability to make an impact or walk away from the day feeling fulfilled if they were to leave bedside nursing. But what I think we find through the conversations in this podcast is actually nurses are able to, kind of hunt down their passion and make an impact in a way that they're really passionate about, end up in a role where they do end up fulfilled every day when they're not touching a patient.
Yeah, my kind of success measures are using the data. So if I implement maybe a mental health solution, 1 year, 3 years down the road, as I'm assessing this solution, am I seeing decreased mental health spend, decreased ER visits related to mental health, maybe even upticks in, because we want people to utilize the things we have in place. So maybe an uptick in people that are seeking and going to outpatient therapy. So I really use the data to be my validation of, okay, this was a great recommendation and it's going really well. But as you know, not everything is successful, but you have to be able to assess that data and then pivot if need to recommend something else or new strategy to engage members. So using the data is how I kind of have my successful patient outcome.
Absolutely. If someone listening today thinks that this sounds like a super interesting career path, what advice would you give to a nurse who's, still in the bedside role, looking for change? What advice would you give them in pursuing a path like yours?
I really do believe that my insurance experience is the primary reason that I have been so successful in this role. Understanding that ecosystem has been just so beneficial. I feel like I can talk shop for if I'm talking to someone that's primarily insurance or focusing on the clinical. So there are a lot of case management jobs. Within an insurance company, too, you may have heard of utilization management. That one requires a lot of attention to detail. You're reviewing charts, but you still will get a sense of how the insurance interacts with how healthcare is carried out. So I would say if you are looking to go into population health in a similar route as mine, trying to get in with an insurance company, also third-party administrators, TPAs, usually are hiring registered nurses. You'll have a pretty standard 9 to 5, maybe a weekend here or there where you have to work. But being able to gain that insurance knowledge was very beneficial to just being able to best match the issue with the solution.
Right. Yeah. And it is such a complex landscape healthcare in general, but insurance too. And it's something that a lot of us never really see the behind the scenes of. And you've mentioned a couple of times that you did a lot of just like on the job learning. Were there any kind of prerequisites or courses or classes that you needed to take in order to kind of level yourself up? Or is this something where, you had a baseline set of skills that you needed, you learned a lot on the job and were able to progress from there?
Yeah. So when I was at the insurance company working as a case manager, to me, I love learning and seeing what type of additional learning can complement the job that I'm currently in. So I got my certification in case management. That was really great on just learning, some more keys to best managing someone from a case management perspective. Case managers don't have to be registered nurses. Some of the best case managers at Blue Cross that I worked with were social workers. Even in the hospital, oftentimes social workers are filling that role, and I can completely understand why. But case management made me more well-rounded in the case management process and gave me ideas of unique ways to leverage outside resources. So getting that certification. And then when I moved over to the broker space, I was actually required to get my Illinois Life and Health producer license. So that was a very in-depth focus on really all types of insurance. So life insurance included, different benefits, and starting to, which, that can be a whole nother subject of how even someone's life insurance policy could be a great spot for a registered nurse to be at. But that really focused me in. And then when I came to the Horton Group, we had a clinical analyst here named Judy, and she brought 40 years of experience. I always tell her she was like a trailblazer. She was within the insurance space, 40 years ago, doing wellness and population health. And for me, I was like, I think you're the first registered nurse that I've ever met with that many years of experience outside of clinic nursing or bedside nursing. So Judy Mueller gave me a lot of insight onto population health, but it felt a little bit intuitive for me as well. I've always really liked data. I've always been interested in analytics. So for me, it just was a very happy marriage of a lot of my interests that worked out in my favor, I guess.
Yeah, absolutely. Well, that's good to hear. I know that, if nurses are looking for jobs away from the bedside, sometimes it feels so daunting to even come to understand what's required, what's not. Working, especially in the hospital, we come from a very regulated place where everyone who is doing a specific job has a specific license, certification, to do what they're doing. And of course, there are jobs and roles that do have specific requirements, but I would say that a lot of the time, we probably think in our mind as nurses that it's a lot more involved in that than it generally is. And even sometimes, you can find like that an employer will pay for whatever certification is needed for a job. So it's not like you're having to start over and go back to school for a completely different degree. I naively, when I was looking to leave the bedside, I was like, well, do I have to go back to school for business? You just don't know. We're so used to how regulated everything is in healthcare. So it's really helpful to have you kind of lay out the steps that one would need to take. And on-the-job learning is amazing. And if you can find a good mentor, like it sounds like you had, that can make all of the difference.
Yeah, mentorship is something that's so important. So like I've had the two nurse mentors, my manager at Blue Cross and then Judy when I started in my current role with the Horton Group. But being able to make connections outside of your department is really where, to your point, that business side of things really starts to flourish, because some people do have their MBA that you're working with and they're willing to share their knowledge and their thought process. So you find someone that just has, open arms and wants to be able to just drop you a little pearl of knowledge here. Just keep going with that. I feel like apprenticeships, I know hospitals try to do that like very standard mentorship program, but I've found that one of my mentors at the Horton Group, Mike, he probably doesn't even really know, but he'll be like, oh, I noticed you kind of repeated what I said in that prior meeting. He's like, flattery is the best form of impersonation. I was like, yeah, he's very knowledgeable. He's worked within the insurance space for many years. So whatever knowledge that they're willing to share with you, just kind of like latch on and absorb what you can.
If you'd like to connect with Natalie, you can find her LinkedIn profile in today's show notes. Thanks for tuning in. Don't forget to hit subscribe to keep up with our latest episodes. And if you were inspired by today's conversation, I hope you'll share this episode with someone who'd love it just as much as you did. If you're ready to pivot your path, visit the job board at jobs.mypivotpath.com. And if you have any questions or just want to say hi, feel free to email me at audrey@mypivotpath.com. Thanks for listening, and we'll see you next time.